all of these very selective radiotherapy needs special procedures, because we have to make a geometrical object from the patient first. Because if she is not laying down during the fractionated radiation, do you remember what was the conventional fractionation size? Fraction size. I'm speaking too many things to you. Was it 10 gray per day?
No, 200.
Yes. 2 grays, yes. 1.82 grays. And if we would like to destroy a tumor with 70 gray, how many days it is lasting? Yeah, 35, yes. 35 days, it means 7 weeks or 8 weeks, yes. So, and each day the patient should be in the same position as it was planned. We have one plan and we have to put the patient exactly as it was planned. This is one problem. The other problem is that everything can change within the body of the patient. During the radiation, there is a swelling in the treating region. The patient is breathing, the lung is moving, the liver is moving, and so on and so on. The bladder can be filled, a flatulation may occur, and so on. So there are a lot of things which are changing, and we have somehow to assure that the therapy is given the right place, because we were able to plan this therapy in a millimeter accuracy. And therefore, there is a very defined procedure line, starting with patient positioning, prescribed or defined for each radiation of each region, and we should position the patient as optimal for the treatment delivery. And we should not think about how to get rid of the irradiation of the arms if we can ask the patient to elevate the arm, and so on. So we can do a lot of very easy and simple things with using the patient's ability, and it is very important to use the communication with the patient and to let the patient understand what is the aim of this whole thing. And we can use several devices to get better position for the radiation. And of course, this is unnatural position to lay down like this, but we have to make all of our efforts to be as convenient as possible, otherwise the patient will move and to try to get rid of the inconvenience. So this is the patient positioning, which should be applied already for the imaging for radiotherapy planning. And the immobilization, the different lot of types of immobilization, which is used to get a better reproducibility and to stabilize this position, both for the intrafractional radiation delivery and for the fractioning, the repeated repositioning. And thereafter, different imaging is taking place. Nowadays, the CT is the basis because of the electron density which is needed for the dose distribution calculation, but all of the other images, PET, CT, MRI, can be fused, and the information of this image information can be used for defining the gross tumor volume, and from starting of the gross tumor volume, we can define the planning target volume finally. Thereafter, the planning takes place, after the defining the target volumes and the doses, the dose prescription, the planning takes place, and after the delivery should be, the radiation delivery should be in a very controlled manner applied, and after a while there should be some control on the changes of the body and to adapt the radiation approach, our radiation approach to the changes. So some examples, this is a head and neck irradiation, and these are radiopack markers which can be identified in the planning system and which help us to define the treatment geometry. And these are laser lines which are used for positioning, and diodes which are as well as used for detect the good positioning. This is a special thermoplastic mask fixation used all over the patient's body. It was thoracical irradiation. This is a prone irradiation of the rectum, and this larger is the thermoplastic mass fixation, the better is the fixation. It can be used as well as for craniospinal or for abdominal irradiation. And almost the whole patient can be covered by thermoplastic mass. And it is very advantageous, for example, for a small child, because they can watch video during the therapy. And this is a vacuum pillow which you can use separately from the mass fixation as well as fixation device. This is a prostate irradiation, and all of these devices should fit into the treatment imaging, treatment planning imaging devices. This is, for example, the CT, and the brain can be imaged by MRI without the same fixation, because it's a geometrical body, practically a half spheric geometrical object, so it can be easily fused with CT images. And the PET-CT gives us immediately the CT data and the PET data as well as, and we can use the same. It is hardly to see, but believe me, this is the same immobilization used during the PET-CT. And this is the methionine PET, for example, the visualization of the brain tumor, high-grade glial tumor. And this is the PET-CT, FDG 18 fluoro desoxyglucose of head and neck cancer, and you can see that how hard it would be to define the target volume without the metabolic information, and the metabolic information helps us to define finally the target volume. And we have, of course, a part of target volume, we have to contour the patient contour, the outer contour, and all of the organs at risk, like, for example, for breast irradiation, the lungs, the heart, and finally all of the targets, the different regions of lymph nodes, mammaria interna, axillary, and so on, and the breast itself. And if everything is ready, we have contoured everything slice by slice, we have to prescribe the dose, which is easy for us because we have protocols, national and international guidelines, certain tumor, how many doses should receive. We have to define the target dose, the fraction size, and the dose constraints of normal tissues. What do you think? How we prescribe the dose constraints, for example, for the lung?
It depends on what type of cancer does it have, I think. Non-small cell maybe, or because the cells are different in
yes,
shaping.
how we describe the dose of the target. Yes,
they're
exactly.
different in shaping, and then the gas transfer is different also. So maybe you.
But for target dose, if we don't use the painting, generally we give one number. We say that we would like one number of the dose and one number for the fraction size. So I say that I would like to irradiate this volume with 40 gray in 20 fractions. So two numbers I give for prescription, dose and fraction number. What I give for dose constraints. And I suppose that the physicist will plan a very homogeneous dose to the target, and each little part of the target will receive this 40 gray. But how I prescribe the...
Isn't it WT, the waiting?
No. I should give a lot of numbers. I can define the maximum dose, which should be not overstepped. I can give the mean dose, which I don't want to get higher dose. For example, for lung. And I can give of each little volume a certain number, a certain dose, which I don't want to have higher. Do you understand that? So for those prescription of the target, I give only 2 numbers, but from those only 1 number. I would like to give 40 gray, but I don't want to give more than 8 gray for the whole lung, and I don't want to give more than 35 gray for 5% of the volume, and I don't want to give to step over a maximum dose of that and that. So finally, I have to define very carefully all of the dose of the target, the fraction size, and the dose constants, and I get as a help national guidelines, tumor type, and so on, and I have to take into consideration additionally the other therapy modalities which the patient receives. For example, if the patient receives additional chemotherapy, which is acting as a radiosensitizing agent, I have to take into account. And the standard method of calculation is a phenomenological approach, and the convolutional methods, pencil beam calculation or collapse cone calculation, and most advanced is the Monte Carlo simulation, which is really calculate of each atomic reaction if we define the material composition. And how we evaluate the plan, we can visualize the dose on a table, and this is the volume and the dose in the axis, and you can see how many parts of the volume receive what amount of dose. And you can evaluate both the target dose distribution, which is actually our aim that it should be as homogeneous as possible, so it should be handled by the prescribed dose, which is not possible, of course. We have always a compromise, and we can visualize the dose of the organs. And for more advanced radiation, we can define the coverage index, the dose which is really covering the isotopes, which is really covering our target, the conformity. This means how selective is our radiation, and the homogeneity within the target. And of course, the dose should be measured as well as not only calculated, whether the measured and the calculated doses should be the same. And there are a lot of defects from ionizing chambers to different chemical methods, the photographic films, and you see all of the methods. And we can measure the dose in different phantoms, which is the majority of the patient is water equivalent, a part of the bones and the lungs, and the water phantom is which is mainly used by the anthropomorphic phantom. And recently, for each individual plan, we have to verify this plan in different ionizing phantoms. And the treatment is done so that we have to control the patient setup each day it is possible. We use for the setup the laser lines and the outer landmarks, but we control it with AP, with TV images, recently with cone beam CT, and more recently with MRI images. And the adaptation of the changes should be taken place as well as because it is in the middle of the radiation of a lung tumor, and you can see that after only 40 gray, we at the end will deliver 72 grays to this patient, and after 40 gray, we have seen a relevant tumor shrinkage, and all of these images you can see this shrinkage. So finally, we can adapt our plan by defining again the contours of the different structures. And the quality assurance issue is very important as well as in the radiotherapy department. We have to have regular control of the machines, regular measurements, daily, weekly, monthly, on the delivery of the ionizing radiation. The whole procedures should be controlled, and the protocols which we are using, and so on. And finally, with all of these efforts, hopefully we will increase or we will achieve a good therapeutic effect. So this was the introductory part for the conventional radiation. Do you have any questions? Yes?
Sorry, I know with PET-CT for every lesion there is an SUV, and for applying radiotherapy to those lesions, there is a minimum SUV for that, or doesn't matter the SUV uptake?
There are several approaches to use PET-CT, and I myself, I like better than this static SUV concept, which is always 2.5 or in this region, in between 2.5 times the normal uptake, or higher, or sometimes 3 times. But I like much better the dynamic approach, where because in the different regions, for example, for head and neck tumor, for the lymph nodes, and for the head and neck tumor itself, I mean, the tumor can be in different surrounding tissues, and for that it is better if you use a dynamic evaluation of the SUVs. With the help, I have to say that in my department we have a radiologist who is controlling all of our target volume, all of our gross tumor volume delineation on the basis of MRI imaging and everything what we have used. And there is a nuclear medicine expert as well as who comes and helps us to define where is the tumor in this patient where we have seen the high metabolic uptake regions. Yes? And sometimes there are some regions which have physiological high uptake. So we have to be very careful to use just PET-CT.
Hemorrhoids are one of those high uptake without being, I don't know, cancerous?
No, it's rather highly functioning areas, or maybe which normally, but sometimes there are some inflammation. It is very typical, for example, that a tumor can be surrounded with inflammatory reaction, and it causes as well as higher metabolic activity, higher glucose metabolic activity, and it should be separated from the tumor tissue.
Thank you.
And I have not mentioned, but there are approaches to develop automatic segmentation tools by informatics, and this may help us. One of this such like development I have seen, it started to get the metabolic data from PET-CT and then to use the MRI data for head and neck to really define the contour of this volume. But first the visualization was, or the algorithm was focused on the PET-CT data, on the high uptake value, as well as defining the static thresholds, and thereafter the MRI has helped to the program to find the contour of the tumor. And now we go to the hadron therapy. So we were stopped here that the conventional radiotherapy has reached its maximum from the point of view of selectivity and accuracy. And the hadron therapy occurred to some developers, and they use these subatomic particles, the mesons and baryons. For example, neutrons and protons are baryons composed of quarks, up and down quarks, and protons and neutrons from 3 to the proton is 1 down and 2 up quark, and the neutron is 2 up and 1 down quark, and key meson is in between from 2 quarks, and this is the list of different ions, different particles, nuclear particles, which we can consider as hadron therapy recently, but you will see that only some of them are really used. And what is the advantages of these nuclear particles? That on one side, they have a much higher physical selectivity due to their dose depth curve, due to their characteristic charged particles, how they absorb in a material, and with that we can achieve higher physical selectivity of dose delivery. And on the other hand, there are particles which are densely ionizing with high linear energy transfer value, like fast neutrons, like heavy ions, carbon ions, which have, as well as a part of the high physical selectivity, a high biological effectivity, except fast neutrons, which have only high RBE and not a high physical selectivity. This is what I have mentioned, that the charged particle has this favorable depth dose, which is characterized by the Bragg peak, which means that the particle gives its energy at a slowing down process only in a low degree, and at a certain depth, depending on the energy, it gives all of its energy all of a sudden. You can see that the different energy proton or charged particle has the different penetration depth. And this Bragg peak can be enlarged, but for the price of enlargement of the entrance dose as well as. But if you compare it to a cobalt or an X-ray or a neutron dose depth curve, it is still better, still favorable from the point of view of the tumor irradiation. If you can imagine with low number of beams, if you can imagine that the tumor is positioned over there, then you can have very nice dose on the tumor and less dose prior to it in the neighborhood. And the lateral fold of this beam can be as well as quite favorable. And it is only to remind you that the high LET results high RBE, so there are particles like neutrons and between the charged particles, the carbon ion, for example, which have high linear energy transfer, densely ionizing properties, and you can see it is a well demonstrated drawing. What does it mean? That it increases the number of strand breaks, double strand breaks in the DNA, and the oxygen enhancement is less important. What kind of hadron therapy sources we know? It can be applied as well as the conventional therapy. We can use cyclotrons, synchrotrons, reactors, research reactors, for example, or maybe at a certain time laser accelerated particles. But there are alpha emitters or neutron emitters which can be used as brachytherapy, not well spread. I have to say it's rarely applied. And there is an interesting approach of thermal or epithermal neutron use with a capturing agent which may capture the neutron and will disintegrate into particles which are irradiating in the cell itself, which are released in the cell itself and irradiating a very small part. The cyclotron idea came already in 1992, and there resulted a Nobel Prize, and the first cyclotrons were such like huge machines, and during 5 decades, this therapy was applied in such like physical circumstances. There were no hospital-based machine. And in these circumstances, the first physical experiences has been collected, first with single fraction neutron irradiation, then Stone and Larkin has irradiated more than 200 patients, And in 1948, a lot of cyclotrons has been built, and this Geneve Memorial Lecture shown that the neutron therapy has resulted much more damages than benefit for the patient. It was really awful. Nobody knew that this relative biological effectivity concerned not only the tumor cells, but as well as the healthy tissues. The patients came back after years with non-healing, deep ulceration with lot of suffer. And it has stopped for a while the development of hadron therapy, especially the neutron therapy. But later on, it has a renaissance, a little renaissance, and there were hospital-based machines with collimation, with rotating gantry, which at least could be delivered the dose a little bit more selectively, and therefore it could be used for certain type of tumors. And I think that nowadays only 4 in South Africa and Washington, Seattle, there are 3 centers which are still operating neutrons. Maybe in München they use some neutrons still for palliation. Yes. Yeah. Okay. But I have not written for that. So some words about boron neutron capture therapy, which was as well as possible and tried with fast neutrons, slowing down them, but the principle of it is that the boron atom, or there are several atoms which have a high cross-section of neutrons, thermal neutrons, and if it captures the thermal neutrons, it will be excited and disintegrates into 2 particles, because the boron 10 itself is not a radioactive atom. But if it captures the neutrons, it disintegrates into particles in helium, alpha particle, and lithium, and it gives its energy within some micrometer range corresponding to the cell diameter, so we can consider it as a selective cell targeted energy deposition with very high densely ionizing properties, with very high RBE, and it is a binary approach. Both of them can be optimized, but it is so highly, it has so highly complexity that it has been not developed further. It needs a lot of research, a lot of money, because only to consider the dose which is absorbed from this reaction, the boron reaction, you have seen the alpha and the lithium particle, but there are a lot of nitrogen in the human body, and the neutron component has its those impact, and the photons, which cannot get rid of the production by the production of the neutrons. So finally, it seemed to be hopeless to handle this lot of those components and the boron carrier material optimization, but nevertheless, there are some phase 1 studies which have been performed in the Netherlands and in the US in a common effort, and recently in Japan there are several centers where they perform DNCD still now, and they have published some promising results with recurrent head and neck cancer irradiation, as well as such like publications came from Finland, from Helsinki. And there are several other considerations with gadolinium, neutron capture, but finally it has been used, the boron neutron capture therapy with BPA, with borophenylalanine and borocaptate for glioblastoma, multiforme melanoma, and recurrent head and neck cancer in the clinic for nothing else. But the charged particle therapy has been much better developed with proton therapy and heavy ions. To remind you, it is very nice dose depth curve depending of the bracket position from the energy, and you can see in comparison of electron or X-ray, gamma ray, neutron dose depth curve. And some type, again, reminding you that the carbon ions having a much more ionizing properties. And we have to mention only shortly that, however, we are considering protons as almost the same RBR values than the photon therapy. 1.1 is the general multiplicative